Let me get right into it and invite our first speaker, and that will be Professor Gesine Meyer Rath. She is a medical doctor and health economist working on the economics of infectious disease interventions in low and middle income settings. She's a research professor in the Department of Global Health of the School of Public Health of Boston University in the US, and a principal researcher at the Health Economics and Epidemiology Research Office, HERO, at the University of Witwatersrand in Johannesburg, South Africa. Dr. Meyer Rath's research focus lies on modeling methods for economic evaluation and translating research into recommendations for public policy, in particular for the HIV and TB programs of South Africa and other South African countries. Welcome, my good friend.
Thank you very much, Eva. Do we have my presentation? Can I see it? Oh, but I can't see it. Okay, all right, because Okay, perfect, thank you. All right, why do we talk about economics? You will all have heard of the term that economics is a dismal science. What gets lost is the starting of that particular statement. It's by Carlyle, and it actually starts with the contention that economics is not a gay science. It is dreary, desolate, and indeed quite abject and distressing. And all of that is because economics starts by being concerned with the value of inputs and their optimal use in producing outputs under existing constraints. So in other words, if we had all the money and other inputs that we need in the world, we would not need economists, and I could go right home. We know from our daily life in trying to influence policy, implementing things we care about, that all of that involves making choices between different options, and all of those involve trade-offs. As economists, we try to put numbers to these trade-offs, and by doing so, we often talk about opportunity cost. So by putting money towards one thing, you will forego the benefits you could have reaped from other things, which is measured as opportunity cost. We talk about time preference, which talks about a universal preference of people to have benefits now rather than later in an uncertain future. And we very often also talk about uncertainty, which is one of the reasons why people tend to regard models or modelers with a certain amount of caution. We can't, however, get away from the fact that costs and other economic aspects are never the first, and they must never be the first, but are almost always the second concern regarding a new intervention. And as such, they stand between the science, the effectiveness, and the actual implementation. And we would all wish this to be otherwise, but in particular this year, the year that we've had, has brought it back home that we can't do what we want to do if we don't also know what it will cost and what someone needs to put into a budget for it. So I'm almost done. I just want to go through this very quickly. A lot of people talk about something being cost effective and then that sentence ends. And I hope by the end of this session in particular, none of you will make that mistake. Cost effective is always in comparison to something else. If you have a comparator, so an intervention in the middle here, you could talk about the cost and effectiveness of something else in relation to this comparator. And that gives you 4 different options. Either you have something that's less costly, more effective, gives you more life years, saves more people from infectious disease, whatever it is, and it costs less, and there's absolutely, this is what we call a no-brainer, there's no debate about it, absolutely go straight ahead, do it. If you have something that costs more but is less effective, again, absolutely straightforward, don't do it. If you have something, and this is relevant this year in particular, that is less effective but also less costly, it's a bit of a, it's hard to see in this color, but basically there is a debate about whether or not you should do it. You're saving money, but you're also wasting lives or whatever it is. That is always open for debate. But almost always we find ourselves in this quadrant where things are more costly, but also more effective, and now we have to make a decision. We live in this quadrant. Looking at that in a bit more detail, and we are almost done with the Health Economics 101, we have different ways of making decisions here. Comparing this intervention A with the intervention B, what helps us here is a threshold that allows us to solve this problem again as a binary problem and turns it into don't do it, do it. This threshold can be defined in a number of different ways, including by an approximation of either the whole society's or a government's or a global funding entity's willingness to pay for a defined unit of health benefit. These thresholds have been differently defined over the years and decades, and it's all a bit confusing, but I'll break it down very quickly. Either this threshold is already known, and that's true for a number of health systems, including the UK and Australia, or in the past we've had this very simplistic directive from WHO to base it on productivity, so measured as certain numbers of GDP per capita per a unit of health. That's no longer the case. Or you base it on opportunity cost, which is a fairly complicated comparison of past increases in life expectancy and past health expenditure. If you divide the one by the other, you get to certain threshold values. For South Africa, this has been established as being around about $2,000 for a metric that we call the disability adjusted life year. This is the second option. The third one is to look at what has been spent in the past and what the cost effectiveness of those interventions are, in particular in the area that you're most concerned with, for example, in HIV or in TB testing or whatever it is, and use the cost effectiveness of those already funded interventions as a guide to what is acceptable for the decision space you're looking at. Whatever it is, an intervention can only be considered cost-effective if it is compared to something else, an intervention, a threshold, or both. So the sentence, something is cost-effective without additional information, is basically meaningless. Okay, looking at the economics of HIV, harm reduction, and hepatitis in turn, in HIV in South Africa, we have a very simple well, it's not simple, it's actually a fairly comprehensive system that allows us to put data at every step in the HIV and TB planning and budgeting cycle. It's taken us about 15 years to build this kind of ecosystem, and we're still very much involved in refining it, but this is roughly how it works. We start with EPI estimates delivered by a national and provincial level HIV transmission model called TEMBISA. We have additional estimates at the district level contributed by an UNAIDS supported model called NAOMI. To this we add cost estimates. Those give then rise to estimates of cost effectiveness, which in a good year inform a set of optimized intervention and intervention targets, which again give rise to policies, guidelines, national plans, including the strategic plan, national level budgets, and then this, because this basically is a churn that we do every single year, from there we can go to provincial budgets, provincial implementation plans, and implementation itself. And because HIV and TB policies are implemented at the level of 9 provinces in South Africa, we also then have an opportunity of looking at how well the budgets are executed and the targets are met, which then in turn give rise to new service statistics, which on an annual basis are used to update our EPI estimates by providing a new baseline, as well as where needed to new cost estimates. Now, of course, we are not doing this on our own. Most of those are actually processes that are fully underwritten and overseen by the national and provincial departments of health, as well as our National AIDS Council, SANAC, and a number of other academic partners. So HERO is not alone in this, absolutely not. This is just this is the TEMBISA model, a little bit more detail on that we are using in South Africa, fairly being one of the few countries that basically is allowed to use its own homegrown model for official UNAIDS HIV estimates, in contrast to the spectrum model that's otherwise being used. It has a great number of stratifications. What it does not yet have is an estimate of people with drug use. So that is a stratification that we're still working on. We then contribute a number of cost estimates, and so from the HERO side, we have costed, when it comes to HIV, probably every single intervention there is. We start from effectiveness, and then we add cost estimates to that. So we've supported the ART rollout and increases in eligibility for essentially the last 16 years. Switches in first-line treatment, we've supported HIV testing and self-testing rollout, as well as looked at every single PrEP option, and most lately we've helped the government arrive at an affordable and acceptable, in particular, threshold price for lenacapavir, which was one of the factors that shaped the current price reduction, etc. So this then, as we've seen in that circle, goes into the investment case, so both the cost and the EPI estimates, which is essentially an allocative efficiency optimization. I won't go into this in too much detail, but what's important here is that we look at the most cost-effective mix of intervention and intervention coverages that are affordable under the currently committed budget. In the past, that used the committed budgets from the South African government, which funds about 80–85% of the total HIV response from domestic resources, as well as Global Fund and PEPFAR. And then we continue past that budget constraint. That gives us a constraint optimization, but we continue past it to see what would be additionally available if we had more money, and that's then our unconstrained optimization. And Eva nods along because she and UNAIDS have been very much instrumental in setting up this entire system about 15 years ago. Yeah. So we do this every year, and every year we are able to then say, do more of this, do less of that. It's almost always more of this. When we first ran it in 2016, this was roughly the order of interventions under the budget envelope. Every single year we run it, condom provision is the most cost-effective, in fact, the only cost-saving intervention. Back then it was followed by increasing medical male circumcision, scaling up ART further, scaling up PMTCT, increasing PCR for infant testing, as well as a number of social and behavior change communication campaigns. And that was all that was affordable under the current budget. If there was more money available in the unconstrained optimization, we suggested adding a whole number of additional testing interventions in yellow, as well as more prevention interventions in blue. And so over the years, these things have changed because the funding envelope has changed, the baseline coverage has changed, the incremental cost effectiveness of each of those interventions changed as a result of those two things. And so what we saw, however, every single year is that increasing ART further, and now not so much the initial initiation and coverage, but really retention and linkage interventions is one of the most cost-effective interventions, followed by then additional testing depending on how much money is available, as well as prevention interventions. The budget has, for HIV, from, again, mostly funded from the South African government, has increased, and so has expenditure above inflation. These are real numbers for the past 20 years, and that was true until COVID hit, where after a first increase in the HIV budget, which was basically the vehicle for COVID funding, we then had a decrease of the HIV expenditure altogether because of the decrease in our available financial fiscal space. Of course, that was before PEPFAR defunding hit. What's happening in South Africa at the moment, and this is a very recent analysis that we just published in AIDS, is that we have lost about 17% of the funding for HIV, in particular key population activities, as well as our entire data system. We modeled that depending on whether or not this would only be for the next 4 years for the duration of the current US administration or into perpetuity, we would be losing, or we would be facing an additional HIV infections between 150 and 300,000, between 56 and 65,000 additional AIDS deaths, and that's just in the next 3 years. as well as first a decrease of HIV program costs, but then, as you can see, those blue and pink lines crossing the black baseline and being higher, basically increased cost annually from 2028 onwards. But what's more concerning is really this, sorry, that's the decrease there, but what's more concerning is those yellow backward pointing arrows that show that we are looking at losing decades of progress against HIV in South Africa. And of course, that the same is true for any number of high prevalence countries, and colleagues have done that for other countries as well. Okay, so that's HIV. We're doing well. Right now, we're sliding backwards. When it comes to harm reduction, the picture is a little bit more sketchy in terms of how much has economics actually helped to make the case. There is a number of different population size estimates in South Africa. I'm sure they have been mentioned across the conference. These are the three biggest surveys that we use. And as you can see, they come in with values between 0.5 and about 2% of adult people. This is now adult men, but it's more or less the same for the entire population. And if you compare that with the size of other key populations, and I know this is a bit hard to see, but here we compare to female sex workers, MSM, as well as trans women, I think only. Those basically PWID are the smallest key population in South Africa, regardless of which survey you look at. We also did a number of economic analyses. So this is a cost analysis of what was back then called opioid substitution therapy. I know that's no longer the language, where we were asked by government to cost an opioid substitution therapy implementation plan for 21-25. And we did this work in 2019. We found that this is the cost per client served per year, with maintenance therapy mostly based on or actually exclusively with methadone, but also with NSP, etc. We found that clients could be served in 55 PHC sites, cheaper than with the mobiles, but the mobiles would be necessary for outreach. The total budget for this for 5 years for this implementation plan was about $34 million, and it never got implemented, and we believe that affordability was one of the reasons for that. There's actually for South Africa not a single economic evaluation, so full evaluation looking also at the outcomes for OST, but there has been one that was done as basically a case study for a completely different purpose. This was done by colleagues at Priceless, also at Wits University. It was an indicative analysis that was then used to basically ask experts and test their consideration of ethical factors to inform coverage decisions for the South African universal health coverage system, the National Health Insurance. And in this analysis, which was really just a background case study, the colleagues found that OST would be, or the cost effectiveness would be just above our threshold, so would not be cost effective based on the South African opportunity cost derived threshold. The recommendations there were to do more OST specific prescriber training with a view to basically enable nurses to prescribe the scheduled drug, to have patient registers, as well as add methadone to the essential drug list. In terms of hepatitis, South Africa has done a bit more, and I'll also talk about a couple of global exercises. Firstly, in terms of the burden in South Africa, and I would imagine that has been mentioned a couple of times along this conference as well, but the general population prevalence is about 7% for hepatitis B, looking at antibodies, as well as 1% of the population are estimated to be chronic hepatitis C carriers. The latest survey in PWID, this is a BBS Lite that has just been published by our National AIDS Council, that suggests, and this is just data from 6 different districts, and the data's on the right there, suggest a prevalence of hepatitis B of 14% and of hepatitis C of 60% in PWID. And this was not a question that was asked, but there was likely no access to DAAs, which is not currently available in the public sector. There was also no question about needle sharing behavior, but just looking at these couple of socioeconomic indicators, where a third had been or reported to have been in jail in the last 6 months, a third were homeless, and there was a very high prevalence of food insecurity, suggests that needle sharing is likely a risk factor here. There was also a South African investment case for hepatitis a couple of years back. This is from 2018 from Hecht and colleagues. They did not, however, explicitly look at PWID. This was, again, for an action plan that was introduced by a government, including birth dose vaccination for hepatitis B, PMTCT for hepatitis B, as well as treatment for hepatitis B and C. This came in as a cost of 294 million over 4 years, but also was deemed very effective in averting deaths as well as cases, and came in as an incremental cost effectiveness of round about $3,000. And as you will perhaps just about remember, that is very similar to the cost effectiveness of OAT that we've seen just now, also just above the cost effectiveness threshold. Amongst these interventions, birth dose vaccination was considered most cost effective, and that was a single element of this policy that was actually introduced. My last couple slides before I wrap up are about global investment cases, firstly for hepatitis C. So this really looks at a great number of countries and makes the case for hepatitis C elimination through testing and treatment according to the 2030 WHO elimination targets that could, again, avert millions of deaths and 10 millions of infections globally between 2018 and 2030. And most importantly, and us economists kind of, our greatest joy is when we see crossing over total cost lines into the future, because that suggests cost savings to us. What's happening here is that the blue line of the baseline, is that true? No, the red line, that's the status quo, so the baseline, the comparator, the cost of that, which slowly goes down over time, is crossed by both the progress and the elimination, so progress increasing coverage, elimination increasing them to the level that would allow elimination. Cost lines in the in the almost immediate future by 2027. And that is because in this analysis, the authors included the economic benefit of putting people back into work and basically cashed that up as well. So this is called a cost effectiveness analysis from the societal perspective. And basically they estimated that this globally, this elimination policy could generate 46 billion in cumulative productivity gains because it costs 42 billion. Basically the remainder, the 23 billion, would be in cost saving. Now, this is not money that anyone can put back into a budget, but it is, at the societal perspective, money that is generated by people being able to productively contribute again. Similarly, for hepatitis B, only there it takes a lot longer. Again, millions of infections, millions of deaths averted. At a better cost effectiveness than the global hepatitis C case. But here we would be waiting for a very long time. That's the curve in the upper right there, to see an actual net cost saving. So those lines don't cross until 2050. This is also much longer model time frame. Okay, so in summary, what do we know, what don't we? What we know is that for South Africa, further expansion of HIV testing, treatment, and prevention is cost-effective and has been affordable for every time in the last 15 years that we looked. Programs are now under threat, in particular for key populations. When we last looked or did this analysis, OAT was deemed unaffordable in South Africa. We urgently need in South Africa, in the region, lower drug prices for both methadone and buprenorphine, which wasn't included in this analysis, but would be a much more effective alternative, as we know. And both hepatitis B and C elimination could be cost-saving once you include proactivity impacts, and hepatitis C from as soon as 2027 onwards. What we don't know is the full cost-effectiveness of OAT in any African settings. We have not done any such analysis. This would have to include the effects of preventing hepatitis B and C and improved pregnancy outcomes in PWID, and would also need to include the impact on caregivers' productivity as well as clients' own productivity. We also haven't done a full cost-effectiveness analysis of directly active antivirals for hepatitis C anywhere in Africa. And of course, we don't know the full impact of the US GED funding on key population programs at this stage. We have scattered data available. We heard a bit about it in the last session. But in particular for PWID, the data is not there. And that's all for me. Thank you very much. A lot of people have contributed to this.